dear teachers, colleagues, and students. I thank this alumni for giving this opportunity to deliver my lecture. Now I going to discuss something about chronic kidney disease and how to evaluate when we see the patients with chronic kidney disease. Chronic kidney disease is the big problem in Sri Lanka. Every day we lose about 7 to 10 patients with chronic kidney disease without proper dialysis or transplant program. Here, chronic kidney disease mainly due to chronic kidney disease unknown etiology. So far, we couldn't find out exact reason for this chronic kidney disease. In Sri Lanka, North Central Province, about 12,000 of population, mainly young population, suffering from chronic kidney disease. But in Northern Province, mainly the Vaunia, Mannar, and Klinochi, there are quite number of patients with chronic kidney disease unknown etiology. We call it as CKDU. But in Jaffna Peninsula, the chronic kidney disease mainly due to secondary to diabetes, as mentioned by Dr. Sivansudan earlier, and hypertensive nephrosclerosis, and fair number of polycystic kidney disease. We every day getting patients with chronic kidney disease to our clinic and inward management. Therefore, everyone better to know how we evaluate the patient when received with chronic kidney disease. First, we see what is the definition of chronic kidney disease. In 2002, Kidney Disease Outcome Quality Initiative Guidelines classify CKD into 5 stages based on GFR and the presence of associated renal abnormalities, either proteinuria or hematuria or radiological or histological, that means morphological abnormalities of kidneys. In 2008, NICE guidelines modified the chronic kidney disease classification further in stage 3 into CKD 3A according to the glomerular filtration rate between 45 to 59 and 3B 44 to 30 milliliter per minute. When we receive any patient with chronic renal disease, our first aim to categorize what is the stage, that is give further plan of management. Usually stages of kidney disease and frequently according to estimated GFR, we classify it. Stage 1, 2, 3, 3 further divided into A and B, and 4, 5. Because these are very important for further investigation and management. If stage 1, the estimated GFR more than 90 with other evidence of kidney damage like hematuria, proteinuria, or morphological or structural kidney disease. And stage 2, the estimated GFR between 60 to 89, and these patients, we can test the renal function like serum creatinine, electrolytes, hemoglobin, calcium, 1 in 12 months. Stage 3A, the estimated GFR fall between 45 to 69, and 3B, 30 to 44. There is moderate decrease in GFR with or without evidence of kidney damage. This patient we follow with a repeated test at least once in 6 months. And stage 4, the estimated GFR fall between 15 to 29, severe decrease in GFR with or without evidence of kidney damage. This patient we follow with a repeated test at least once in 3 months. When stage 5, that's end-stage renal failure, the estimated GFR usually less than 15, we follow this patient at clinic at least 6 weeks interval with reports. These stage 5 patients, they need renal replacement therapy in the form of dialysis or kidney transplant within a couple of months. Otherwise, we're going to lose that patient. The stages of chronic kidney disease, easy to remember in anticlockwise. From anticlockwise, from 12 o'clock to 9 o'clock, it is 90 to 120. 6 o'clock to 9 o'clock, 60 to 90. And 3 o'clock to 6 o'clock, 30 to 60. And 0 to 30, 3 o'clock, 0 to 30. This is easy to remember, everyone, the stages of chronic kidney disease when we see the patient with estimated GFR. What are the advantages of current CKD classification? It simplifies the categorization of people suffering from CKD, increase the awareness of CKD among nephrologists, non-nephrologists, and public at large. In the past, increased number of people suffering from CKD were not recognized because they had serum creatinine within normal range. Usually, you see the patient around 40 or above that with normal serum creatinine. Without doing the estimated GFR, we diagnosed, labeled as normal kidney. But actually, if you do the serum estimated GFR, is usually low limit. Therefore, the estimation of GFR, very good index, we can suspect the disease early and treat properly. Just go through the serum creatinine alone, most of the time, we miss the patient and end up in problem. It has allowed assessment of the impact of different level of GFR on outcome, including cardiovascular disease. How common CKD? The true incidence and prevalence of CKD within the community is difficult to ascertain because early or moderate CKD usually asymptomatic. Therefore, the screening of the patients is very important with high risk factors. We come later. Epidemiological studies have suggested prevalence of CKD worldwide 10% and estimated GFR less than 60, around 3%. End-stage renal failure, about 0.2%. In Sri Lanka, even in Jaffna, we don't have exact number of incidents of prevalence. But our clinic in Jaffna, we have registered patients, about 500 patients. Out of that, about 90 to 100 patients on regular dialysis. Who should I screen for chronic kidney disease? When we see the patient with hypertension, diabetes, there is family history of chronic kidney disease, or patient who have recurrent urinary tract infections, or systemic disease that can affect the kidney, such as vasculitis or SLE, excessive or prolonged use of analgesic, or NSAID. This is a common problem in Jaffna, or even in Sri Lanka. Any patient come with pain, always prescribe, without looking the serum creatinine level, they start this NSAID for any pain. Because of this NSAID, the big use of NSAID, the one of the important reason, another reason for chronic kidney disease in Sri Lanka. Therefore, we advise the doctors who are going to prescribe NSAID, at least check baseline creatinine and check when patient on long-term NSAID, at least 3 months serum creatinine. Otherwise, we end up in end-stage renal failure. Is low GFR sign CKD in older patient? The majority of individuals usually lose kidney function with age. From the age of 40 or 50 onwards, reduction of GFR around 0.5 to 0.8 ml per minute per year. This loss is due to either physiological or pathological. Loss of GFR with aging is a reflection of more generalized vascular aging process affecting the kidney. In the absence of significant proteinuria, the renal prognosis of older individual with CKD3 is good because very few progress to end-stage renal failure. Therefore, we receive a lot of patients around 40 and 50, 60 years with the CKD3, but they have put good prognosis because this low GFR mainly due to vascular abnormalities. How common end-stage renal failure? The prevalence of CKD around 10%, but prevalence of end-stage renal disease 0.2. Why this discrepancy? One, lack of progression of CKD3 in majority of elderly. We see a lot of patients with CKD3, estimated GFR around 30 to 60, but their prognosis is very good. When we assess for last 10 years, the prognosis is very good because the kidney impairment mainly due to their age, not due to other disease. And most of the patients died due to other diseases before they reaching stage 4 or 5. Therefore, the end-stage renal disease prevalence is comparatively very low compared to chronic kidney disease. What is the natural history of CKD? The natural history of CKD depends the cause of the CKD, the stage of the CKD when we see the patient first time, and presence of hypertension or not, and presence of proteinuria or not, and severity of complication of CKD. The main culprit of chronic kidney disease get deteriorate very fast. One is proteinuria, other one is uncontrolled hypertension. The presence of ACE inhibitors and angiotensin receptor blockers, it keep both reduce the proteinuria as well as control the blood pressure. Therefore, patient with chronic kidney disease, when we are going to start the antihypertensive drugs, the ACE inhibitors or receptor blockers is the ideal one. Then we can delay the progression of chronic kidney disease. In diabetic nephropathy and glomerular disease, found to have much faster rate of CKD progression. Therefore, they need well control of the disease. Those suffering from hypertensive nephrosclerosis or chronic interstitial nephropathies found to have much slower rate of CKD progression. In addition, CKD progression can be accelerated by intercurrent infection and illness, use of nephrotoxic drugs like NSAID or aminoglycosides, and superimposed acute kidney injury. What are the causes for chronic kidney disease? There are a list of causes, but in Sri Lanka, the main cause of chronic kidney disease is unknown etiology. The WHO funded a lot of investigations going on. So far, the exact cause for chronic kidney disease not found. Anyone interested, join the program, you may get Nobel Prize to detect this chronic kidney disease in Sri Lanka. There are other causes: inherited, adult polycystic kidney disease, inflammatory disease, infective disease, metabolic, vascular, toxins, malignancy, glomerular disease, tubular interstitial disease, congenital, and hypertensive nephrosclerosis. Worldwide, the common cause for chronic kidney disease, diabetic and glomerular disease. But in Sri Lanka, CKDU. What are the risk factors for CKD? Age, uncontrolled hypertension, and family history of chronic kidney disease, smoking. Heavy and sustained smoking associated with proteinuria, it increased the progression of kidney disease faster. Hyperlipidemia, obesity with albuminuria, and poverty. What are the factors affect the rate of progression of CKD? This is very important. When we see the patient with chronic kidney disease, our main aim to delay the progression. Therefore, the control of hypertension is very important. And reduce the proteinuria by using ACE inhibitors or receptor blockers. If contraindicated, we can use calcium channel blockers, non-dihydropyridine group of calcium channel blockers better. High dihydropyridine group of calcium channel blockers like nifedipine, amlodipine, not good in patients with chronic kidney disease. Most of our patients we see, patients with the hypertension are on these drugs, nifedipine and amlodipine. These are not good drugs for patients with chronic kidney disease. And poorly controlled diabetes and exposure to nephrotoxic drugs. Whenever we start any nephrotoxic drugs, always check the baseline serum creatinine and estimated GFR before starting. If it is normal, better to recheck at least 1 in 3 months. Otherwise, most of the time, we get the patient at end-stage renal failure with symptoms. Acute or chronic exacerbation, CKD, the main reasons are nephrotoxic drugs and underlying obstructive disease, mainly prostatomegaly. And pregnancy, patient with chronic kidney disease who become pregnant, they shows accelerated impairment of renal function. Therefore, we advise the patient with chronic kidney disease not become pregnant. Otherwise, difficult to manage, patient become pregnant. Right. How should the patient with CKD be approached? Usually when we see the patient, history examination should guide the investigation. All patients should go following investigation, creatinine, estimated GFR, full blood count, ultrasound abdomen, iron study. Patient with urinary abnormalities, we go for further evaluation with autoantibody, CNK, ANF, and complement level and virological study. How should we measure the proteinuria? There are various ways of measuring the proteinuria. Urinary dipstick test, 24 hours urine protein, or spot urine test, protein creatinine ratio, or spot urine albumin creatinine ratio. Does not measure the tubular protein or light chain, better indication of glomerular disease, this albumin creatinine ratio. How does the CKD patient present? Most of the time, we incidental finding, they come for other disease. When we do the routine test, we detect. Finding on routine screening with high-risk group, like diabetes and hypertension, for usual test, we detect. And symptomatic patient, they are very late presentation. Most of the time, end up in complication. They come with uremic symptoms related to systemic inflammatory disease with a renal involvement, either lupus or Wegener's, and obstructive symptom of symptomatic proteinuria. What are the manifestations of CKD? They come with asymptomatic urine abnormalities, reduced GFR, or they come with hypertension, or come with nephrotic or nephritic syndrome. What are the complications of CKD? The CKD usually associated with high incidence of cardiovascular disease, hypertension and coronary artery disease, congestive heart failure, calcification and accelerated atherosclerosis, stroke, and peripheral vascular disease. And other complications due to disease itself, anemia, mineral and bone disease, and malnutrition. Why the patient with CKD develop anemia? The most important reason is erythropoietin, which is secreted by kidney, is reduced due to renal impairment. Therefore, most of the patients need erythropoietin treatment. And resistant to erythropoietin, iron deficiency. When we see patient with the chronic kidney disease, just serum iron or ferritin level not indicate the iron status of the body. We have to measure transferrin saturation. If the transferrin saturation is less than 20%, the functionable iron element in the body is not adequate. When you start erythropoietin, they don't work. Therefore, the patient with saturated transferrin saturation less than 20, we have to calculate and give parenteral iron treatment before starting erythropoietin. Otherwise, the erythropoietin not help to improve the hemoglobin level. Other reasons, excessive oxidant stress and chronic blood loss are the cause for the anemia in CKD. The most of the patients we see CKD are malnourished. There are inflammation, malnutrition, inflammation, atherosclerosis, Mia syndrome is the important cause for loss of weight in dialysis patient. Then we also advise the diet restriction with low phosphate diet may lead to protein malnutrition. Therefore, they are malnourished. Therefore, the handling of patient with CKD while on dialysis, we always advise to take normal diet with low fat, low salt. When we see the patient, how should I manage the patient with CKD? There are two cornerstones of management. Prevention of CKD progression, that is the main aim, and management of CKD complication. Can I prevent the progression of CKD? Yes. In general, progression is associated with poorly controlled blood pressure. Our aim to maintain the blood pressure less than 130 to 80 and reduce the proteinuria less than 1. So we need to do the following: optimize the blood pressure less than 130/80 or better 125/70. Reduce the proteinuria by using these drugs. The clinical trials renin for non-diabetic CKD and renal for type 2 diabetes nephropathy. These studies says the two important part in the management of CKD, one is control of blood pressure, bring down below 120/75 and reduce the proteinuria. If you do these two things, you can delay the progression of chronic kidney disease. If you see the patient with stage 2, if you do these two, you can delay 10 years or 15 years to start the dialysis. This is the two important message, take-home message for the management of CKD. And control of other factors, dyslipidemia by using statin, stop smoking, that is very important, avoidance of nephrotoxic drugs, and low salt diet, and maintain the target body weight. Patient with chronic kidney disease not to become malnourished, not to become obese. These are very important goal in management of CKD. Can I prevent CKD progression? Yes. Optimize BP, correction of anemia, improvement of calcium phosphate hormone, vitamin D axis, treatment of dyslipidemia, stop smoking. How can I minimize or treat anemia? Correction of any deficiency, mainly iron, better to give parenteral and erythropoietin. Target of hemoglobin 11 to 12, not above the 12 or not below 10. Both are danger. If you start erythropoietin and check every month hemoglobin, if hemoglobin achieved our target, better to stop erythropoietin and recheck the hemoglobin once a month or 2 months time. If hemoglobin is static, then avoid erythropoietin. If you continue to give erythropoietin, then they increase the chances of bone tumors. Therefore, we have to see both sides. How to treat bone and mineral disturbance? Mainly correction of hypophosphatemia by restriction of protein and phosphate binders. We can use patient with the low calcium. We use the calcium-based binders like calcium carbonate, or patient with the calcium level while in dialysis, we use non-calcium-based phosphate binders like sevelimer or lanthanum carbonate. How can I minimize or treat malnutrition in CKD? Patient on dialysis, we optimize the dialysis. Patient with diabetes, every other day we have to do dialysis at least 4-hour session. Non-diabetic patient, we can manage with 2 dialysis sessions per week, and high quality protein diet, and we have to provide maximum calorie and control metabolic acidosis, correction of underlying infection or inflammatory process, and correction of anemia, maintain hemoglobin around 11 to 12, and stimulation of anabolism with recombinant human growth factors, insulin growth factor 1. Right. This is the way we manage. When the doctors at the GPs, anyone, see the patient with a renal problem, when should I refer my patient with CKD to nephrologist? According to NICE guidelines, any patient you see at stage 5, CKD stage 5, should refer to nephrologist for further renal replacement, either dialysis or kidney transplant. All the patients with CKD stage 4, unless renal replacement therapy by dialysis is not considered as an option. And CKD 4 and stage 5 should be referred for optimal preparation for renal replacement therapy. CKD 3B should be referred to assess the potential. For further investigation, we refer to nephrologists with CKD 3A with decline in GFR or CKD 3A and significant proteinuria more than 1 gram, and CKD 1 and 2 with significant proteinuria more than 2 grams or 3 grams, and CKD 1 or 2 severe proteinuria and hematuria, we have to refer the patient. In Sri Lanka, there are 6 places they do the dialysis. but the amount of patients in Sri Lanka is very high. The number of dialysis facilities very limited. Altogether, 130 dialysis machines available in Sri Lanka. Therefore, our aim to reduce the progression of chronic kidney disease whenever we see the patient, delay the progression by years and years by doing simple things. Correction of anemia, control of blood pressure, control of underlying disease, reduce the proteinuria, advise stop smoking, and follow the clinic regularly. Thank you.